All right, welcome. I'm Becky Sippel from the University of Wisconsin Endocrine Surgery. I want to thank you all for coming to our first Facebook Live. Today's session is really to answer your questions related to endocrine surgery. So the question might be, what exactly is endocrine surgery? So endocrine surgery is a specialty of general surgery, and it's surgeons who are committed to the care of patients who have endocrine problems. Most commonly, endocrine surgeons will take care of patients with parathyroid, thyroid, and adrenal problems. Sometimes they'll take care of neuroendocrine tumors of the pancreas or of the small bowel. So what makes an endocrine surgeon different than another surgeon? And I would say that an endocrine surgeon is unique because they don't just understand the technical aspects of how to do an operation, but they also understand the endocrine background of the disease. So they're really good at helping to diagnose a problem with an endocrine disorder and also how to manage the hormonal problems both pre and post-operatively. And so I think when you see an endocrine surgeon, you really are able to get comprehensive care for your endocrine condition. I like to say that I consider myself an endocrinologist who just happens to operate to help solve problems. And so I really think that anything that you would typically see an endocrinologist for, if there's a surgical option for it, then the endocrine surgeon is the right person to see. Now, we did in today's session ask for people to submit some questions online. So thank you to all of you who were able to do that and to provide us with some questions. A lot of those questions were pretty specific about your specific scenario, involving your details of your case. And while I can't necessarily answer very specific clinical questions about individual cases in this format, I tried to simplify those into sort of broad-based questions that I think will address all the important issues that were brought up by those cases and hopefully answer all of your questions. Now today's session really is geared on both thyroid, parathyroid, and adrenal problems. But that being said, I think most of the questions that came in are related to parathyroid disease. So I thought I would start with a few questions related to the thyroid, and then we can move on to the parathyroid questions. If at any point during today's session you have a question that you want an answer for, please just type it into the comments section, and we're happy to try to address those and respond to those real time. So let's get started with some of the thyroid-related questions.
All right, so our first question is, does RAI for thyroid disease increase the risk of parathyroid problems?
So what that question is that radioactive iodine is a treatment that's often used to treat both thyroid cancer as well as hyperthyroidism. And when people get that treatment, there is a low dose of radiation exposure to their thyroid gland. And the question is does that lead to consequences long term? And I think that there is good data to show that that low dose radiation exposure to the thyroid, because the parathyroids are directly adjacent to it, they do get some adjacent exposure. And there's probably just a little bit of radiation exposure to those parathyroids, and that patients who've had that treatment typically will have a higher incidence than we would expect of developing hyperparathyroidism later in their life. Typically, the latency period between that developing is somewhere between 10 to 20 years after your radioactive iodine treatment. So I don't think the incidence is high enough that we necessarily need to screen every patient who's had radioactive iodine, but if you've had that in your history, it's certainly something to keep track of. Now, there's also concerns about radioactive iodine treatment and the risk of other malignancies or other cancers. Does that radiation exposure increase your risk? And I think that has been studied in several large studies, and the rate of increased risk of cancer is small, but statistically detectable. So overall, the risk of radioactive iodine treatment is incredibly low, and the risk of you developing another cancer from that treatment is incredibly low. But in a large population of patients, there is a slightly higher risk of other cancers than what you would expect. And those cancers tend to be in tissues that are processed, that the iodine goes through. So that would be things like the stomach, the urinary system, and especially for women who are lactating, their breast tissue can get some exposure. So while there is a slightly higher risk of cancers, it's not a very substantial increased risk, and I wouldn't recommend screening for other cancers just because you've had a history of radioactive iodine treatment.
All right, so our next question is about management of permanent hyperparathyroidism. Is there a role for autotransplant?
Yeah, so I think that permanent hypoparathyroidism is sort of a disastrous consequence of either thyroid or sometimes even parathyroid surgery. Whenever we remove the thyroid, our goal is to preserve the parathyroids with an adequate blood supply and to keep them safe and healthy and working normally. But occasionally, despite our best efforts, they just don't function normally, and patients can have trouble with too low of parathyroid hormone levels. And in the opposite of too high of parathyroid hormone levels, they have trouble regulating calcium, and their calcium levels are chronically low. When their calcium levels are chronically low, that can cause paresthesias in their lips or fingertips. It can cause muscle cramps. It can just make people not feel well. Sometimes people have to take calcium 2, 3, 4 times a day in order to help manage those symptoms. For many patients, if it ends up being a permanent problem, we can usually regulate people with a combination of calcium supplements as well as vitamin D supplements. And not the typical over-the-counter vitamin D, but a prescription form of vitamin D that is already activated, which just helps you to absorb calcium more effectively. In some cases, the problem is severe enough that just doesn't effectively manage it, or the patients need medications multiple times a day, and it's just not a good quality of life. And in those scenarios, there is now a new treatment option available. There's something called a recombinant parathyroid hormone, or the trade name is called NatPara. And what that is a synthetic form of parathyroid hormone that's injectable that you can be given once a day, which helps to reduce your needs for supplemental calcium and vitamin D. It isn't a cure-all for hypoparathyroidism, but it certainly can help to reduce your needs for chronic calcium and vitamin D supplementation and may make the condition more manageable in the long term. So if you're in the scenario where it's a chronic condition, that's a great option. The other option that you mentioned was autotransplantation. And I would say autotransplantation is something that we often do at the initial surgery for patients with either parathyroid or thyroid problems. And what that involves is taking a parathyroid that's from you, that's yours, and removing it and then potentially putting it into a muscle so it can regrow blood supply. So if we're doing a thyroid surgery and a parathyroid gland looks like the blood supply is damaged and it's not going to work normally, instead of letting that parathyroid die, what we'd like to do is remove it and then mince it up into small pieces and put it in a muscle, maybe in the neck or in the arm, so that it can regrow blood supply and start functioning. If that's normal tissue, then that's the ideal way to do it. What we never want to do is send parathyroid tissue to the pathologist, because all they're going to do is tell us it's parathyroid tissue. And if there's any chance that you as a patient need it, then we want to make sure that you get that tissue. Now, in parathyroid disease, it gets a little bit more complicated because if the tissue is being removed, it's usually abnormal. So we don't necessarily always want to do an autotransplant. But occasionally in patients who have multi-gland disease or have familial disease, we will remove all the tissue from the neck and put some in the arm, so that if it continues to grow and causes problems, the reoperation is a little bit easier because you're dealing with it in the arm. I think the challenge with autotransplant is that it has to be your natural tissue. We right now don't have any ability to take someone else's parathyroid tissue and to give it to someone else. Your body will think it's foreign and will reject it. And so for right now, that's only an option for you with your individual tissue. It's not going to be an option for you to get a transplant from somebody else.
All right. How do you make a diagnosis of hyperparathyroidism, and what calcium is considered abnormal?
Yeah, so it seems like a lot of the questions that we got really had to center around parathyroid disease and the struggles that people have had in getting this diagnosed. And I would say that when we look at calcium, the normal range of calcium is between 8.5 to 10.2, at least at our institution. And that varies based on what your lab's, levels are. But I would say that that's a range for an entire population of people. And every individual person probably has a much smaller normal reference range. So sometimes you can look back historically at your calcium levels and see what have they been in the past. And maybe your calcium levels in the past have always been 9 or 9.1, and now it's 9.9. So historically for you, your normal range was probably more 9 or 9.1. So now 9.9 is actually a pretty significant change for you. So I think it's always important to sort of look historically at what your calcium levels have been and to sort of see, has there been a gradual trend over time that level is increasing? And is it especially in the normal range, but at the high end of the normal range? I would say that it's pretty uncommon for a normal, healthy adult to naturally have a calcium at 10 or above. Officially, 10 to 10.2 is in the normal range, but I would say it's pretty uncommon for a healthy woman to have a normal calcium in that range. So sometimes, even though your calcium is labeled as in the normal range, it's really not what we would define as normal. I think if there's a trend towards a higher calcium level, it's always important for you to compare that to what your parathyroid hormone level is at the same time. I like to think about it sort of as a teeter-totter. If your calcium is high, then your parathyroid level should be low, or it should be suppressed. If your calcium level is high or even high normal, and that parathyroid level isn't low, then that doesn't make sense. It means that the glands aren't responding to each other the way they're supposed to do. And so that tells us is that you likely have some parathyroid autonomy or some parathyroid dysfunction. So I think when you're trying to make a diagnosis, obviously if the calcium is super high and the parathyroid hormone level is very high, that's really easy to make a diagnosis. But sometimes there's cases where it's much more borderline. And then we want to look at calciums that are in the high normal range or mildly elevated. And then in that case, what we want to do is say, what does the parathyroid hormone level look like? And is that where we would expect it to be? And I would expect with a high calcium for the parathyroid hormone level to be below the limits of normal or probably under 20.
All right, how do you define success of an operation?
Yeah, I would say that everyone has different techniques on how they approach parathyroid surgery, and I would say that there's different adjuncts that you do. You probably have heard of different techniques, one called a minimally invasive approach, and one called a bilateral exploration or an open parathyroidectomy. And I think that you have to do the approach that makes the most sense and gives you the best outcomes. I think a minimally invasive approach was developed because probably 80% of people have just a single gland that's enlarged. And if there's only one gland that's enlarged, it would be nice if we could do a more focused operation and just remove that one gland and not necessarily have to do a more extensive operation. So to determine if you have a single gland, that's where imaging often is obtained. So I would say the first step in making a diagnosis is by labs. You want to make a diagnosis based on the laboratory evaluation. And then once you're confident of the diagnosis, then you can say, if we're going to do surgery, what's the best approach? And that's where the imaging is helpful. Sometimes we'll get an ultrasound or a sestamibi scan or a CT scan. And what gets done probably varies based on the provider that you see and their comfort level. But I would say that all of those have their individual strengths and weaknesses. But if that imaging shows a discrete enlarged parathyroid gland that looks convincingly like an adenoma, then you're a good candidate for a minimally invasive approach. Then what we would do during surgery is target that one gland, remove that gland, and then what we do is during surgery we want to confirm that those other glands are truly appropriately suppressed. So we would check intraoperative parathyroid hormone levels. And those are typically sent 5 to 10 minutes after the gland is removed. And if the levels drop appropriately, then we know that you're cured. And so we'll end the operation, and we won't necessarily go looking for those other 3 glands. If, however, during surgery those levels drop, but not quite as reassuringly as we would expect, or the gland is enlarged but not quite as enlarged as we would expect, or it looks more hyperplastic, meaning just kind of diffusely enlarged and doesn't look like an adenoma, then the safest thing is to identify all 4 glands. I think it's always a balance of who's going to be best served with a lesser approach and who really needs that 4-gland exploration. And I think a lot of that relies on the judgment of the surgeon. But the goal is to make sure that everybody gets cured at their first operation.
What are the limitations of intraoperative PTH levels?
I think when intraoperative PTH or intraoperative parathyroid hormone level testing first came out, everyone kind of thought it was the magic test and it was going to define cure on everyone. I think the challenge for us is that it is very helpful, but it is not perfect. There are some patients where that level drops and it doesn't drop quite enough, but people sort of say, well, if it drops by at least 50%, they're cured. I would say a good example of this is, let's say your parathyroid hormone level is 100, and at 5 minutes it falls to 55. That's a nice drop. And then the next one comes back at 50. Now officially it's been a 50% drop, and that's supposed to be reassuring. It's in the normal range. That's supposed to be reassuring. But I would say I would be concerned because it went from 100 to 55 to now 50. I would expect if there was really only one gland that was overfunctioning, it should really go from 100 to 50 to 25. It should continue to fall until that level is 0. Because at that time in the operating room, you're still hypercalcemic. Your calcium's still elevated. So if those other glands are working appropriately, they should be suppressed. So I think sometimes the challenges with parathyroid hormone testing is that people are a little bit too aggressive in interpreting that's good enough or that the patient is cured. I think there's also a chance where somebody could have a double adenoma. And sometimes there are two glands that are enlarged. And there is one that's dominant and then one that's a little bit smaller. And that dominant one is actually suppressing the smaller one. But it's only after you remove the large one that second one sort of wakes up and starts hyperfunctioning. Sometimes you will notice that on the blood testing in the OR, but oftentimes that really doesn't become apparent until 2 weeks or even a few months after surgery. So those are the causes where the PTH levels fail, where it misses that there is actually a second gland. And I would say it's not the end of the world when that happens, because if you've truly had a minimally invasive approach, somebody's just gone in and taken out that one gland and checked your parathyroid hormone levels, they haven't created scar tissue anywhere else. And so if you need a second operation, it can be done very easily. There isn't any added risk to going back. It's just going back in as if the levels hadn't dropped in the operating room and just finishing the operation and looking at the remaining 3 glands.
Is the success rate the same for an MIP or a 4-gland exploration?
Yeah, so I think that, as I sort of alluded to, I do think that MIPs, there are certain, or the minimally invasive approach, there probably is a slightly higher failure rate with that operation if it's not well selected. So if patients are offered that when maybe their localization wasn't perfect, or the blood levels didn't drop as reassuringly as they should have. So there maybe is a slightly higher rate that those patients will end up having a recurrence. But like I said, the advantage is if that's been done, it's not that big of a deal, because that second operation is a very straightforward operation. There's really no scar tissue, there is no added risk to going back to finish that operation to look for the remaining 3 glands. Now, if somebody has had a 4-gland exploration or a bilateral exploration and they've identified all 4 glands, hopefully, if they know what they're doing, they really have been able to determine, are those glands abnormal or not? And so I would say if it's an experienced parathyroid surgeon and they've identified all 4 glands and they look normal, you can feel pretty confident that the problem will be taken care of. I think the challenge for us, as a specialist in that, is sometimes people will do that bilateral exploration, but don't necessarily have the experience or the expertise. And so when they do that, they think they found parathyroids, but they're not certain, and they can certainly misidentify other tissues as parathyroids. And so in those cases, it's hard to really know which glands have been truly identified and which ones haven't. And the downside of that is that there's a lot of scar tissue created. And so in that scenario, if you're not cured or we have to reoperate, there's a lot more scar tissue and the reoperation becomes much more challenging. And so I think that there's certainly a role for a minimally invasive approach, and I would say especially if a surgeon doesn't have as much experience, I would favor that they did a minimally invasive approach, because I think if you're not cured, it becomes much easier to offer you a successful reoperation if you've had less surgery done the first time.
Does the extent of the first surgery impact whether you are willing to do another operation?
Yeah, so I guess that sort of led into that. That's what I was just talking about. I do think that if somebody has had a minimally invasive approach the first time, I'm not at all hesitant to offer another surgery, because I really don't think that adds significant risk. But I do think if the first operation was a more extensive, 4-gland exploration, or I've seen patients who've had 5 and 6 hour operations in their neck, it becomes a lot harder for us to go in and just find the parathyroids. We really can't identify normal glands in a situation like that. What we really have to do then is rely on imaging to tell us exactly where the abnormal gland is so that we can successfully find it. So I would say that at a first operation, I'm not very dependent on imaging. I typically will ultrasound patients myself in the clinic, and that's negative. If they want to just go directly to surgery, I'm fine with that. But I think for a reoperation, I'm much more dependent on imaging. I'm much more likely to want to get additional imaging. And typically, in an ideal world, I want to get something that tells me anatomically that looks like a parathyroid. So either an ultrasound or a CT scan that shows that. And then I also would like to get some functional confirmation. So sometimes that is a nuclear medicine study, like a sestimate scan. Sometimes that would be a venous sampling study or a biopsy, something to show me that there truly is elevated parathyroid hormone coming from that location.
How do you define cure after surgery?
So I would say that a lot of people try to say that they can define cure by a drop in the parathyroid hormone level or normal labs at just 2 weeks after surgery, and I don't think you can really do that. I think that we know, especially that scenario I talked about earlier of a double adenoma, that sometimes that doesn't manifest for a few months after surgery. So I really think that all of our patients should be getting a calcium and a parathyroid hormone level at 6 months. And if those levels are normal at 6 months, then we can say you're officially cured. But until we can confirm that those levels not only become normal but stay normal for at least 6 months, then I can't say that you're officially cured of your disease.
So we have a few questions about labs. So the first question is, when should labs be checked after surgery?
So just as I sort of alluded into the cure question, I would say that, most people, I think it's a good idea to check labs a couple weeks after surgery, just to make sure that they're normalized. It's not uncommon right after surgery that sometimes the parathyroid hormone level is elevated still. And that does not mean necessarily that your surgery was unsuccessful. What that sometimes is a reflection of is the fact that patients with hyperparathyroidism are often vitamin D deficient. And so it may mean that your vitamin D levels still need to be supplemented. It may also mean that you have bone hunger and that your bones are just hungry for extra calcium. It may also mean that your calcium is just a little bit lower than your body ideally wants it to be. So what we want to do in those scenarios is correct those labs. We want to make sure that you're on appropriate calcium supplements, appropriate vitamin D supplements, and that we get those normalized, and then usually check the labs again at 6 months to make sure that they've normalized. If things are still abnormal at 6 months, then I would be concerned that that could represent some persistent disease, meaning that maybe not all of the appropriate glands were taken out. Maybe there's more there that needs to be dealt with.
What if I have recurrent hypercalcemia, but the PTH is normal or high normal?
Yeah, so I think that when we look at a reoperation or after a surgery, it's very similar to what we look at initially. I think we have to look at the calcium and we have to look at the parathyroid hormone level. And so if you develop recurrent hypercalcemia after an operation, that's not normal. And so then what we would have to do is we have to go back to look at how we made the diagnosis and confirm the diagnosis. And so the first step is to get the parathyroid hormone level. And if the parathyroid hormone level is elevated, then there clearly is still more disease. If the parathyroid hormone level is high normal, then I would say they probably have persistent disease. And it probably means that there was one gland that was dominant or one that was bigger than the others, and there's probably additional glands that need to be removed. Now, the scenario, and I think one of the scenarios that was submitted was the calcium that was elevated, but the parathyroid level was low. And I would say that would make me stop and question whether or not this is truly a diagnosis of hyperparathyroidism. If your calcium is elevated after surgery, but the PTH now is nice and low and appropriately low, then I would start to worry that hypercalcemia could be due to other causes. And you could still have symptoms in this scenario because hypercalcemia is what causes many of the symptoms of hyperparathyroidism. So you may have all the symptoms that were attributable to hyperparathyroidism, but now the cause is not necessarily the parathyroids because the parathyroids are responding appropriately.
Does the method of PTH testing impact levels?
So there was one question about whether or not using a preservative, an EDTA solution, would impact parathyroid hormone stability. Typically we will do a parathyroid hormone level and we'll process it in a way quickly so that it doesn't necessarily have to be in a preservative. But if it's from a whole blood sample, it needs to be in that preservative so that it can be run potentially not immediately. And EDTA is meant to stabilize solutions so that they can be run a day or two later and be just as effective. As far as I know, that there is no data to show that can falsely lower parathyroid levels, and in fact, collecting it with that actually helps to maintain the parathyroid levels in a safer, more elevated range than it would through other mechanisms.
What calcium supplements would you recommend after surgery?
So I think that this is a common question. I think what is the appropriate calcium and vitamin D supplementation for people? I would say that I typically would recommend that somebody go on about 1,200 milligrams of calcium a day. That's the daily recommended allowance. Now, if you get that through your diet, That's optimal. Obviously if you can take it in naturally, that's going to be the best case scenario. But if your diet is naturally low in calcium, or you avoid milk products or dairy products, then taking a supplement to get that 1,200 a day is appropriate. Same thing with vitamin D. The national guidelines, recommend that, 400 to 600 international units of vitamin D is adequate. I would say that probably most people need a little bit more than that. Especially where we live in Wisconsin, we don't get enough natural sunlight. So say most patients here probably need 1,000 international units a day to maintain their vitamin D levels in a normal range. I would say that you can probably safely go up to 2,000 international units a day of vitamin D, and that's going to maintain your vitamin D in a safe level. I wouldn't go on any more than that without the supervision of a doctor, because vitamin D is a fat-soluble vitamin, meaning that you can actually become toxic. You can build up stores of vitamin D and get to dangerously high levels. And so if your levels are low and you need to go on higher doses of supplementation, you want to do that under the direction of a doctor to ensure that once those levels have normalized, you go down to a baseline maintenance level of no more than 2,000 international units a day.
Would you recommend magnesium with vitamin D supplements?
So magnesium is helpful for calcium absorption in particular. If your magnesium levels are chronically low, you don't tend to absorb calcium more effectively. So if you are prone to low magnesium levels, you might have trouble absorbing calcium, and you may require large amounts of calcium to meet your needs. So if you have those issues, it may be appropriate to get a combined calcium-magnesium supplement so that you can supplement both of those simultaneously. Typically, vitamin D supplements don't need to be taken with magnesium.
Is there a way to diagnose parathyroid hyperplasia prior to surgery?
Yeah, there is not a great way to know for certain that it's hyperplasia. There are certain clinical factors that would make that more suspicious. So I would say when we see somebody and the labs are mild, the calcium is just mildly elevated, the parathyroid is just mildly elevated, or it's been mildly elevated for a long time. We also sometimes will see imaging that is negative. So I would say the first step is to make the diagnosis, which is based on labs. So if you have relatively mild disease and then somebody orders imaging and they can't find anything, it's not that you don't have the disease, but it does increase the chances of you having hyperplasia. If you have hyperplasia, it doesn't mean that surgery isn't a good solution for you. Patients that have hyperplasia are just as likely to benefit from surgical treatment as those who have adenoma. And I would say when we've looked at this in symptoms, sometimes the patients who have hyperplasia actually have the greatest symptoms. And I think part of it is the chronicity of the disease. Those are the patients that had the mild lab abnormalities, and so it got ignored for many, many, many years before they got referred for surgery. And because of that, sometimes that duration of that chronic elevation of their calcium leads to more symptoms. We did one study that showed that actually neurocognitive symptoms were the worst in those patients who had mild disease. And that would be problems with depression, anxiety, memory, concentration. And I think, again, the brain just suffers from that chronically elevated calcium over a very long time period. So I would say we don't have a perfect test for identifying who has hyperplasia, but we can tell based on your clinical scenario and your imaging who's at greatest risk for it. And I would say that if you have that scenario, that's where it's important to have an experienced surgeon. So if your labs are mild or people are nervous about operating on you because your imaging isn't, really positive, then that's when it's okay to seek a second opinion and to reach out and find a surgeon who feels comfortable looking for all 4 glands and to doing a more extensive operation so that you can be treated for your hyperparathyroidism. I think too often I see patients with hyperplasia that have negative imaging and then are told that surgery is not an option. And that's just not true. Surgery is absolutely an option. You just have to find the right surgeon.
Which is more common, double adenoma or hyperplasia?
I think that's debatable. There's some people who have argued that double adenomas don't really exist. I think they do. We've definitely seen them. I think one of the concerns is that sometimes people are labeled as having a double adenoma, but what they probably really have is actually hyperplasia, and people just didn't appreciate that those other glands were also abnormal, or their hyperplasia was kind of asymmetric, where some of them were much bigger than the others. And so anytime there's a diagnosis of a double adenoma, you just want to be cautious. Is this truly a double adenoma? And the way that I like to define it is to actually look at the parathyroid itself and to see if it's an adenoma. What we will see is we'll see the normal parathyroid gland, and then we will see it adjacent to a growth that looks like a classic adenoma. And if we can see that compressed rim of a normal parathyroid adjacent to it, then we know that that's an adenoma. And if it's an adenoma, then we know for certain. But if they just see that the whole gland looks hypercellular, and they don't see that compressed rim of normal, they may just call the specimen hypercellular. And if that's the case, then you always worry that perhaps this was just hyperplastic disease or hyperplasia, and somebody didn't appreciate it at the first operation. Now, I would say the thing I'd be concerned about is don't look at your pathology report from your parathyroid surgery and be 100% convinced that that's accurate as far as defining whether you had an adenoma or whether you had hyperplasia. Because typically a pathologist, when they process a parathyroid specimen, will cut it in half once. And if that cut happens to go through that compressed rim of normal, then we know for certain it's an adenoma, and they may call it that. But if they happen to cut the specimen the wrong way and it doesn't go through that compressed rim of normal, it doesn't mean with 100% certainty it wasn't there. So sometimes patients that truly have adenomas will have pathology reports that say hypercellular or hyperplastic tissue. And so it's unfortunate, but we just don't have a pathology benchmark to say definitively if it's an adenoma versus hyperplasia. Great. So I think that that's all the questions that we had. I hope that we were able to answer all your questions. If we have other specific questions that we didn't answer, we're happy to set up a session again, and hopefully in another month or two we'll do another session and you can join us then. If you have specific questions and you'd like to meet with myself or any of my partners in our endocrine surgery clinic, we'd be happy to see you at any point in time, and you can reach us at 608-440-6300.